So normal bowel rotates through about 270 degrees to achieve its normal position. And abnormality of rotation can result in a short mesenteric base, which is the risk of volvulus, and that's why the position of the DJ flexure as an indicator. This is a schematic diagram just to show you how the bowel lobes rotate in the peritoneal cavity, and why it's important that the DJ flexure is here and the cecum is onto the right iliac fossa. So that's a broad mesentery, i.e. the fan is not narrow, that it then twists and rotates, causing ischemia. So this again, a schematic diagram shows how you can have a normal rotation, which is why it causes the big broad mesentery, small narrow one, and then it twists around, causing bowel ischemia. There is a classification as the spectrum of malrotations. I wouldn't go into it because it does not have an imaging correlation. In imaging, we have either a highly confident, I'm normal, I'm not worried about it, or, oh, this is very abnormal, I'm not worried, I'm worried about it, go to theater, or I don't know what this is, but it is not normal. That's the third word where we'll be dwelling a lot today. What are the causes of symptoms? Well, symptoms can be life-threatening in infancy. They can also have duodenal obstruction due to latch band, or when they have volvulus, they have severe bilious vomits. But the clinical picture and imaging appearance depend on the nature and degree of obstruction. So it's very, very variable. The only consistent sign I would say is if it's bilious aspirates, you're always worried. So the role of radiology is to clearly give a direction for the surgeon to go in. But at the same time, if you're not sure what you're speaking, if they go into theater and have negative laparotomy, they won't spare you. So gold standard being upper GI contrast study. And I alluded to, I would start with the lateral, go on to the AP to demonstrate the DJ flexure and the retroperitoneal duodenum. A lot of institutions use barium. I still use water soluble, but if I'm not sure, I jump onto barium. I try with water soluble. If I don't get proper pictures, I immediately use barium. The other important statistics to know is if you've demonstrated the retroperitoneum duodenum, that's fine. But the sensitivity of upper GI series reported literature is 93 to 100% for the diagnosis of malrotation and only 54% for the diagnosis of midgut volvulus. So we're still not happy with the holy grail, i.e. upper GI contrast study. So this is give you another algorithm of how we deal with biliary emesis. You might think malrotation volvulus, the commonest symptom is biliary emesis, but sepsis is the more common cause than anything else. So that's why when you have biliary emesis, they tend to seek abdominal radiographs. If you see multiple dilated loops, then they end up doing an enema, thinking it's a distal GI obstruction with back pressure changes. If negative, then they do an upper GI contrast study. But if it's a few dilated bowel loops, they do an upper GI contrast study. But in my experience, what I've seen is answer the question first, which is most dangerous, is to rule out a volvulus or a malrotation. Then everything else can take precedence later. This is an example of an upper GI contrast study. This is how you need to start in the lateral view. Once you start in the lateral, you get a clear esophagus outline. Then the contrast goes into the stomach. Then from the stomach, it goes into the duodenum. It goes into the posterior aspect. And once you have demonstrated that first, second, third, and fourth part of duodenum is on the lateral view, which is retroperitoneum and hugging the spine, you turn the child around and look for the DJ flexure in the AP, and it should be to the left of left pedicle of L1 on the same level as the pylorus, which is what you see in this. It's higher, fine. It's the same level, fine. Slightly lower, fine. If it is more than one vertebral body level below the level expected, I'm not happy. This is again an example of how I do an upper GI contrast study. That's the nasogastric tube. I push it up to the pylorus. I inject contrast. You can see from the pylorus, it has opacified the stomach, both reflux back in the stomach as well as gone into the duodenum. So that's the first part. That's the second part. So that's the third part. And then this is the fourth part, which I said would go towards the intraperitoneal cavity. Immediately, I turn the child onto the AP view. You can see that this is the DJ flexure, and it's to the same level as the pylorus. And the proximal jejunal loops are seen falling onto the left side. And sometimes a word of caution is the first jejunal loop can fall off to the right side, followed by the rest of the jejunal loops on the left side. If I see the proximal jejunal loops on the right side, despite it being retroperitoneal, despite it being at the same level as the pylorus, I tend to get a delayed X-ray to look for the position of the cecum. because if there are proximal jejunal loops on the right side with a high cecum, then I tell the surgeon, I'm slightly worried about this patient because they can have a distal small bowel volvulus, which is the proximal small bowel look okay, but it's the distal small bowel volvulus, which can then present with bilious vomiting and bowel ischemia. So there's a spectrum of abnormality, there's a spectrum of findings, and this is how we chase it. This is an example of a patient in which, if you're not technically careful, you could have easily got it wrong. So one of my colleagues did an upper GI contrast study. You can say they started on an AP view. What did they do? They put some dye in, but what you need to observe is the stomach is very gaseous distended. When the stomach is very gaseous distended, what happens? Once the contrast goes through into the duodenum and comes towards the DJ flexure, would you call that abnormal? I would, based on just this picture, because it's almost in the midline. It's not to the left of the left pediculum, and it's lower than the pylorus. But it just happened that he had the presence of mind to realize that the stomach was very distended. He started aspirating the air from the stomach with an empty syringe. As he kept aspirating, you can see that the DJ flexure actually flicks up, and at the very end has gone very high to the left instead of being so low. So you can move up to 2 vertebral bodies if you're not careful that you have not decompressed the stomach at the start of the study. You underestimate it, but this is an important technical point. So, and that's why I think it's important that we look into this carefully before we do an upper GI contrast study. Next one. This is an example of a bone door malrotation. You can see on the lateral view, the first and the second part of duodenum, instead of going posteriorly or rolling off into the peritoneal cavity anteriorly, and on the AP, you can see that the DJ flexure is somewhat in the midline and very low compared to the pylorus. So that is malrotation. This is an example of a malrotation at volvulus. Why do I say that? Because if you look at the AP and the lateral view, the first and the second part of duodenum looks okay, but as you turn the patient onto the AP view, you can see that the DJ is pretty low. It's nowhere near where the pylorus is. So normally I expect the DJ flexure to the left of L1 pedicle and same level as the pylorus, but it seems to be very low and onto the right side. So this is an example of malrotation with volvulus. Now, is there any role for plain films in volvulus? I don't think so, because what we have in these patients is that there's no specific findings at all. It does show you that there's something wrong. Why do I say that? On the plain film, that there's abnormal separation of bowel loops in keeping with the thickened bowel loops, but other than that, it doesn't say that it's malrotation of volvulus. So plain film is more to judge whether there's obstruction, pneumatosis, or bowel hole thickening, but its ability to say there's malrotation or not does not exist. This again is an example of a corkscrew appearance, which is considered very pathognomonic of a volvulus, which is it goes onto the right side, does not cross as a C loop onto the left side, and it's very tight. This is an example of a low DJ. How low is a low DJ? This is an important question. And the reason I say that is, if you look at this patient presented with bilious vomit. Now, if you look at the duodenum, it seems to go towards the spine and it's hugging it. But if you look at the DJ flexure, it's lower than the pylorus. So these are the kind of patients where you're not sure what you need to say. So what they tend to do in these patients is they tend to observe the patient and look for lactates. If the lactates are rising and the bilious aspirates are not stopping, they tend to go to theater to inspect. They do a laparoscopic inspection to see the position of the DJ flexure. So this is another patient with persistent bilious aspirates in the neonate. So what is interesting is our observation and experience is whenever you see a fluid-filled duodenum on ultrasound, it's almost always abnormal. Duodenums tend to collapse quickly and contrast tends to get away, or contrast or fluid tends to get away quickly. So in this patient, if you look at it, there's a caliber of persistent duodenal opacification with a sort of a rat tail at the very end. And that's because there's a duodenal web. And this patient also happened to have an annular pancreas. So when you see a persistent delayed emptying of the duodenum, you think in terms of, could there be a web? It does not give you the big caliber change which you see in textbooks. That takes a while to develop. These patients present persistently with bilious aspirates. Now, what is important is, if you have not shown me the DJ flexure in this patient, but you have seen a dilated duodenum, it is volvulus unless put otherwise. In order for me to sit on this patient and not take the patient to theater, you have to demonstrate the DJ flexure. If you have not shown me the DJ flexure, it's volvulus unless put otherwise. That's the other important penny dropping moment in these patients when you do an upper GI contrast study. Now, this is another example of a duodenal web. You can see that pigtail-like appearance where there's a caliber change, this yin-yanging to and fro motion. The other advantage of fluoroscopy is you can see this yin-yang motion within the duodenum, which is very useful to predict that there's some kind of obstruction within the duodenum. And this is an example of how you see a classic textbook picture kind of duodenal web, where you've seen distal duodenum and jejunal loops collapsed, and there's proximal dilatation of the duodenum on the stomach. But you don't see this that often. You rather see these kind of pictures more often. And it's important to be aware of this to diagnose duodenal atresia or stenosis. So this is an example of another bilious aspirate. Now, why am I showing you this here? It's because as we have gone into the practice of upper GI contrast study, our practice has evolved. In addition to upper GI contrast study, you can clearly say that the DJ flexures are normal. But we didn't stop there, because in our present day practice, we do ultrasound. And why do we do ultrasound? Is because ultrasound helps to complement to find out on two things. One, can you predict the retroperitoneal course of the duodenum? Two, can you see the normal SMA-SMV axis? Three, do you see a whirlpool sign to say, oh, can this be a volvulus? And four, look for any other cause which could be causing bilious aspirates, because any retroperitoneal abnormality can cause bilious aspirates. So this patient had an ultrasound, and what you see, that's the kidney, that's the urinoma, and that was causing distortion of the DJ flexure. Once they drained the urinoma, and the patient had a posterior urethral valve, which they got operated upon, they repeated the upper GI contrast study, it's normal. So you can get an upper GI contrast is abnormal, does not mean it's always duodenal. If we had not done the ultrasound, this patient would have gone to theater. So prevented an unnecessary negative laparotomy and divert them towards the original diagnosis, which is a urinary problem causing and distortion of the DJ flexure causing bilious vomits. So important to add ultrasound, which is complementary and helps to see if